Good evening. I'm Mary Lee Kiernan, President and CEO of YWCA Greenwich, and I'm pleased to welcome you to this special annual event honoring the life and legacy of Dr. Martin Luther King Jr. Our purpose tonight and every January is to lift up and examine a contemporary issue that Dr. King would have cared about and fought for were he still with us. As the COVID-19 pandemic rages around us with disproportionate impact on people of color, it is fitting for us to present to you tonight a powerful panel discussion entitled Overcoming Racial Health Disparities During COVID-19 and Beyond. We hope you come away this evening with a foundation in the causes, the challenges, and the solutions to the long-standing disparate health outcomes impacting people of color and the racism present in systems within and related to healthcare. Before I begin, I want to thank our outstanding moderator and panelists who have joined us this evening. We are profoundly grateful for their participation tonight and for the life-saving work that they do every day. I would also like to thank the more than 50 community partners who have joined us to co-sponsor and promote this important event, and I want to commend them for their partnership in promoting racial equity. Also partnering with us are our elected officials, and so we will now play a short video with greetings from Senator Richard Blumenthal, Congressman Jim Himes, and First Selectman Fred Camillo.
Hi, I'm Richard Blumenthal, your United States Senator and proudly a member of the Greenwich community. I'm excited and honored to be joining this YWCA celebration of the life and legacy of Martin Luther King in healthcare, and I thank Mary Lee Kiernan and all of the wonderful staff, volunteers, and board members at the YWCA for including me. The pandemic has hit communities of color harder than others, with twice as many deaths there. Only one indication of the continuing disparities that exist, the injustices that afflict our society, and particularly those communities of color. We're in the midst of a racial justice movement, as well as a pandemic and an economic crisis, and we should rededicate ourselves to providing more equality in healthcare, better treatment and prevention for those communities of color that now suffer from lack of healthcare insurance and the kind of medical care that they need and deserve. I pledge myself to that goal. I know you do too. That's the reason you're marking this celebration with a commitment to better healthcare, and I thank you for it.
I'm Congressman Jim Himes, and I'm thrilled to join the YWCA of Greenwich and all of you in celebrating the birthday of that remarkable American, Martin Luther King Jr. I can't think of a year in which it's more important for us to reflect hard on Dr. King's achievements, but also the values that drove him and how he did everything he did. We have seen how much further we have to go in this country for racial justice. We have seen how a terrible virus affected our most vulnerable and most disenfranchised communities far more brutally than it affected others. And of course, coming on the heels of a violent attack on the place where I work, the very seat of our democracy, we see that we have, at least many of us, have lost the sense of how important it is to solve our problems the way Dr. King urged us to do it, through love and peace and respect for the dignity of each and every individual. I think we need to rearm ourselves with the values that drove Dr. King. And if we do that, I know that we're going to solve our problems as a society in a graceful and dignified way. And if we don't, I fear that we may see more of the violence that we saw 2 weeks ago. So happy birthday, Dr. King. We've got a lot to learn from you.
As we look back on the life of Martin Luther King and celebrate what would have been his 92nd birthday, we also should reflect on a lot of his messages that he gave throughout his all too short life. especially at a time where our country is divided and we're looking for answers and direction. His words do mean a lot, always, but especially now. And I always think back at a quote about forgiveness, because right now, where everybody's always pointing fingers at somebody else and keeping score, forgiving really is the first step in healing our country. And Dr. King once said that forgiving is not a temporary act, it's a permanent attitude. And once we can learn that and practice it, we'll be well on the way to being a nation that's united and not divided. Happy Martin Luther King Day.
Thank you to Senator Blumenthal, Congressman Himes, and our first selectman, Fred Camillo. With a mission of eliminating racism and empowering women, YWCA Greenwich is committed to promoting a more just, equitable, and inclusive community. Tonight's free program is part of that effort, as are the anti-racism trainings with our DIVE curriculum and capacity building that we have recently launched in this community. Working on organizational capacity and diversity, equity, and inclusion is a journey, a practice, and a commitment. And we would be pleased to work with businesses and other organizations on assessments, trainings, and co-creation of custom strategies. And now I'm very proud to introduce YWCA Greenwich's new Director of Women's Empowerment and Racial Justice, Erin O. Crosby. Erin will lead YWCA Greenwich's new Center for Equity and Justice, and her expertise and experience represent a new and very important resource for our community. Erin?
Thank you, Mary Lee. It is an honor to gather tonight to remember Dr. King and to actively work toward his vision. Events like this are one component of our new Center for Equity and Justice. Guided by our 4 pillars: community education, direct programming, policy advocacy, and systemic change initiatives, this center will be a community hub for learning and development, research, consulting, coalition building, and research about racial and gender equity. The work of the Center for Equity and Justice will be emergent and responsive, as it should be, shaped by community context and community voices, and rooted in values I believe Dr. King would promote: truth, courage, healing, and liberation from all systems of oppression. Our discussion tonight will embody those values, and we are fortunate to have Tiffany Donaldson moderate tonight's conversation. Tiffany is the president and CEO of Connecticut Health Foundation, the largest independent health philanthropy in Connecticut, and an organization solely focused on improving health outcomes for people of color. Since 1999, the Connecticut Health Foundation has supported innovative grant making, public policy research, strategic communications, and leadership development to achieve its mission. A few logistics before we get started. Our panel discussion will last about 60 minutes, and it'll be followed by Q&A. If you have questions during the event, please share them using the Q&A icon at the bottom of your screen. We'll curate those questions and share them with Tiffany for our panel to answer. We'll conclude tonight's event by 8:30 p.m. So to Tiffany and our panel, thank you, and we'll let you get started.
Thank you so much, Erin. And thank you, Mary Lee, and the entire team at the YWCA for inviting me, but also for initiating this really critical conversation tonight. I also want to welcome and thank all of you who are participating. And I thank you because you're joining because you're interested in really understanding what we can do about improving the lives of all Connecticut residents, and in particular, those who are experiencing desperate outcomes in their health. So I thank you all for participating. We have a great set of panelists and a wonderful conversation ahead of us. So I'd like to give some brief introduction to our panelists, and I am going to keep it brief so that we can jump into the discussion, and we'll provide the full bios for everyone following this discussion. So first, we are joined by Dr. Irene Blanco. She is an associate professor of clinical medicine, as well as the associate dean of diversity enhancement at the Albert Einstein College of Medicine, Medifure Medical Center. She is a rheumatologist by training, and she focuses on addressing health disparities in rheumatology. Dr. Blanco is also focused on further diversifying both the medical and graduate school with the end goal of having Einstein graduates at the upper echelon of research and healthcare nationally and internationally. Welcome, Dr. Blanco. We are also joined by Dr. Juliet Mushi. Dr. Mushi was born in Kenya and spent most of her childhood in Botswana. What is a driving force to the work that she does today is her own personal experience, and in particular, her mother's experience of having to get the approval of her father in order to have a critical female procedure done for her life. And after her own experience, as well as hearing similar stories of women around the world, Dr. Mushi has dedicated her career to obstetrics and gynecology and a subspecialty training in maternal and fetal medicine. In her daily work with the Yale Medicine School at Greenwich Hospital, she supports patients when complications arise in their pregnancies and gains tremendous personal satisfaction from the relationship she forms with her patients. She also has a strong interest in understanding and improving healthcare systems, particular in relation to targeting systemic racism and improving Black women's reproductive health outcomes. Welcome. And last, but certainly not least, we are joined by Dr. Sten Vermund. He is the Dean of the Yale School of Public Health, the Ann M. R. Lauder Professor of Public Health, and Professor of Pediatrics at the Yale School of Medicine. He is a pediatrician and infectious disease epidemiologist focused on diseases of low and middle income countries and on health disparities in the US. Dr. Vermund's research has focused on healthcare access, adolescent medicine, prevention of mother to child HIV transmission, and reproductive health. Dr. Vermund has done some tremendous things throughout his lifetime, and as many of you right now, and as many of you in the field, his recent work has been focused on the COVID-19 pandemic. Welcome, Dr. Vermund. Before we jump into our panel discussion, I was asked to just give a little brief background on why we're having this discussion, what we are experiencing here in our state, and again, to give some context to why we're having this conversation today. So I'm going to share a couple of slides. I'm going to try to make it as quick as possible because, as you heard, our panelists are so phenomenal. I want to give them time to lend their expertise. We have seen this already as the advertisement has gone out, but Dr. King himself, this is a great way to honor him as we talk about health disparities, because he saw and he expressed that inequities and injustice in health is one of the most shocking and the most inhumane. And he goes on to say, because it often leads to death. And essentially he's saying, oh, every life is worth saving. I wanted to provide this background because you're going to hear us use terminology throughout this conversation and interchange it between health equity, health disparities, and health inequities. So we will be talking about health equity as really the systems that will ensure that all populations and individuals have access to their optimal life. So health equity is looking at our systems and its structure that lends itself to people living their healthiest life. Health disparities are the burden of disease that one racial group experiences over another. And the health inequities are avoidable differences in our healthcare system. And so we will be talking about each throughout this conversation. I also wanted to hone in on, we often have the conversation around what is equality versus equity. So if you see here, equality is the state of providing equal resources and distributing them equally throughout. But as you can see in this depiction, if we take our resources and just simply distribute them equally throughout, not everybody can see over the fence. Not everybody can see the game so that they can be part of it. When we talk about equity, we're talking about taking the same amount of resources, but really thinking about who cannot see over the fence, who does not have the access that they need, and how can we distribute the resources in a way that it is fair so that everyone can see over the fence. When I'm often speaking around the nation, people say, why is your organization focused on health equity when Connecticut is deemed one of the healthiest states in America? And it's true. Connecticut in 2019 by America's Health Rankings was deemed the fourth healthiest state in the country. But if you look deeper at that same ranking, we also, as a state, are the 41st in the nation for disparity. So essentially, we're 41 out of 50 as it relates to disparities. We have unequal statistics as it relates to everything from life expectancy to some burdens of diseases as diabetes, cardiovascular disease, asthma, and not just as it relates to the prevalence of the illnesses, but the outcomes, how these conditions inadvertently and disproportionately impact people of color. So what causes some of these disparities? And I will walk through some of these points, but access to healthcare resources, the fact that people of color have desperate treatment in medicine, and the impacts of racism all contribute to disparities. We have done a lot of research as an organization, and what we found is that genetics does not have an impact on disparities in the way we had considered. In particular, when the Human Genome Project was released, they looked particularly at cardiovascular disease to see if there was a reason why there were so many disparities in that condition for people of color. And they found that there was no genetic reason why people of color disproportionately suffered ill outcomes from cardiovascular disease. And there are a variety of studies that are looking at this. And so we know that genetics is not the reason for disparities. Genetics impacts all of our health, but it's not the cause for disparities, the disparities that we see. I mentioned resources, and I just want to hone in. This is Connecticut data. This data is from Data Haven. And this looks at the access to resources that are needed in order for people to really get into the healthcare system and to stay healthy. And I know that Dr. Ramon will speak about this from his public health perspective, but you'll see across the board as it relates to transportation, access to food, neighborhood safety, difficulty affording housing, that people of color, in particular for this statistics and for this work, Black and Hispanic residents are not doing as well as white residents here in Connecticut. And this data is from 2018. When I mentioned in my summary slide the role of race in healthcare, and a lot of studies have shown that there's just desperate treatment when people of color enter the healthcare system. And it is not often conscious. Nobody goes into healthcare thinking that they are going to treat any patient differently one from another. But because of the unconscious biases, because of the structures in our country, it often yields to people of color having different treatment than others. And so there is desperate treatment. There also is just a cost to racism on people of color here overall in the United States and what it means to impact their health. And what I mean by the cost of racism is that research has linked racism to some of the physical and mental health consequences as depression, anxiety, hypertension, breast cancer, and even giving birth preterm. And this is all related to the fact of the micro and macro aggressions that people of color experience often cause them to have physical reactions to it or mental health reactions to it. And so that is why we often say that there is a physical cost to racism for people of color. I'm often asked the question, is it race, Tiffany, or is it socioeconomic status? Is it that people of color are not doing well because they don't have access because of socioeconomic status, or is it because they are a person of color? And I always say it's not a but. It is an and. So socioeconomic status undoubtedly impacts people of color and their disparities. It's because there are differences in education, employment, and housing across the board that limits one's access to the healthcare system overall and limits their access to living their healthiest life. But even controlling for income and education, and we'll hear from Dr. Mushi on this, that people of color still experience desperate impacts to their health. In particular, we have looked at child and maternal health, which is an area that shows huge disparities. And we know nationally that a Black woman with a college degree or higher, they are still 1.6 times more likely to die from pregnancy-related causes than a white woman without a high school diploma, not even a college diploma, without a high school diploma. So this really indicates that holding socioeconomic status and holding education constant, there are still disparities in our healthcare system. Here you can just see that how some of these disparities even show up here in the state of Connecticut. So this is data for the state of Connecticut on infant mortality, and you could see the differences in particular for Black residents in Connecticut versus any of their counterparts. We will talk about this a little bit more, but I just wanted to hone in on where we are today as a healthcare system and how it has impacted where we are in COVID-19. And one of the areas that has risen to the top is distrust with the healthcare system. And this distrust isn't coming from anywhere. This distrust that we're seeing today is stemming from years of mistreatment and mistrust within our healthcare system, going back from the Tuskegee syphilis study to the forced sterilization of Puerto Rican women or Henrietta Lacks. So there are large studies that indicate how people of color have been mistreated. But in addition to that, there are studies that indicate that Black adults often feel, in particular, mistreated anytime that they enter the healthcare system. And all of this is contributing to mistrust in our system. So how has this shown up in COVID? So I talked about some of the gaps in resources that people of color here in our state have. And I talked about just their desperate experience with the healthcare system. We have looked at what is really impacting the disproportionate amount of people of color who are getting COVID. And part of it is that people of color are on the front lines, that they have jobs that do not allow them to work from home. The other point is that they have to work. You know, many of them have less savings and income, so they have to show up. And as I mentioned, there are health disparities across most conditions, and in particular, underlying conditions as asthma, diabetes, and hypertension, which are, as we all have found out, are conditions that make people more susceptible to COVID-19, and in particular, more susceptible from dying from COVID-19. Just so you all see, and I'm going to wrap up very quickly, here is what it looks like in Connecticut. So this data is coming from the Department of Health. And as you can see, as it relates to age-adjusted deaths, that people of color here in Connecticut, particularly Blacks and Hispanics, are dying at much higher rates than others here in our state. And you'll see, and we'll talk more to Dr. Vermond about this and showing up as to why. There are lots of solutions that we as a foundation have talked about, that we will talk about later in this conversation, but I am going to stop sharing and I'm going to stop talking because I want to start with you, Dr. Vermond. I talked about how COVID-19 has shown up for people of color in our state related to deaths. And I just want you to chime in and give us some more information about what are we seeing and the desperate impact for people of color related to COVID-19 and what we saw even prior to COVID-19.
Marvelous, thank you. I'm going to try to get my act together here and pull up the screen just for the audience to follow this. And there's my screen. Can you see it?
Yes, I can see it.
Brilliant. Okay, good. If you can see it, everybody can see it. So thanks, Tiffany. That was an excellent introduction, by the way. I thought you did a fabulous job, and in articulating some of the social and racial determinants of health. A big part of the Yale School of Public Health is tackling these social determinants. One could discover a new drug and improve life expectancy for a certain type of cancer by a tiny fraction. And that would be a good thing for your loved one who had that type of cancer. But if we could fix the social determinants of disease, perhaps we could get to where our European counterparts are already. Of the high-income countries in the world, about 32 of them, we rank dead last, absolutely 32nd. We used to rank above Slovakia, but now they have gone above us. So we have the worst health indices of all the high-income countries, and yet by far we have the highest expenses for our health system, and that's because we are kind of addicted to curative medicine. We'll pay any amount of money for curative medicine, but to find a home for the homeless, to find a job for the jobless, to find a substance abuse treatment opportunity for someone who's got an addiction problem and wants to do something about it, that we underinvest. And the Europeans are the other way around. They realize that the social needs are spectacular and can trump the medical needs. You can accomplish so much by addressing these health inequities and social inequities. Anyway, that's just a sidebar that you inspired with your talk. Let me go to just the one slide I have on race gaps. It's an extension of one of the slides you just showed. This is a cross tabulation of white, Black, and Latino, Latina populations in the United States and death rates from COVID in the first half of the pandemic. And when you look at people who are 85 years and older, Blacks have about double the rate of death as whites, and Hispanics just a fractional higher amount. But then you go back, the younger you are, the more dramatic that difference is. So the referent group are the whites, so they always have the ratio is 1 for them, and then you can see the comparative ratio. And among young people, being a person of color is a massive health risk. Among older people, it contributes, but not as dramatically. So at the end of the day, these social determinants, for all the reasons you articulated well, were dramatic. So I thought I'd spend a little more of my time on a pivot topic, which is that of vaccine enthusiasm or vaccine reluctance. People have talked about the anti-vax movement. We in public health prefer to call it vaccine hesitancy. That's a little less of a judgmental phrase, you know. So this is a question that the Kaiser Family Foundation posed in a survey conducted in November and early December of last year, just about a month ago. And the question was, if a coronavirus vaccine is determined to be safe by scientists and is available for free to everyone who wanted it, would you definitely get it, probably not get it, or definitely not get it? That's what we call a four-point Likert scale. So the data are a little promising. The numbers have risen for people who definitely or probably will get it, from 63 to 71%, but that's still a whopping 29% of respondents who say they probably won't or definitely won't get the vaccine. And we don't know exactly the level of protection we need for us to achieve something called herd immunity, which means that so many people are protected that an individual with a virus bouncing around in their social and professional lives doesn't encounter somebody who's susceptible. The probability of encountering a susceptible person has been driven way down because 80% of the people around this person are immune. And then the virus starts to die out altogether. So this herd immunity is something we'd like to achieve with vaccines. We can't achieve it by just letting people get infected, because you'd have to go for years with millions of deaths before you would achieve herd immunity that way. So the only way to practically achieve it is through vaccination. And, you know, if we can't get 80% of people vaccinated, then we're in trouble. Who's likely to be vaccine hesitant? The people who say they probably or definitely won't get it. So there is a political split. Republicans are more likely to be hesitant than Democrats. There is a racial split, but not quite as dramatic, where blacks are more likely to be hesitant than whites or Hispanics. And I wrote this backwards, I'm sorry. It's households that do not have a member with a serious medical condition. Forgive the error on my slide. So I hope everybody understands, if you don't have someone with a serious medical condition, you're more likely to be vaccine hesitant. If you've got somebody in your household who is battling cancer or battling HIV or has a severe rheumatologic disorder for which they're receiving immunosuppressive drugs like severe rheumatoid arthritis, then your consciousness is raised and you're much more likely to go for a vaccine. And what is the main reason to get the vaccine? It's part of our responsibility to help others is the main reason that a Democrat who thinks that people should get vaccinated is going to respond, and about a quarter of Republicans. But the Republicans are more likely to say it's a personal choice, that's the main reason to get it, is your personal choice to get it. So there's sort of a communitarian philosophy that Democrats are more likely to adopt, and then sort of more a libertarian or individualistic philosophy that Republicans are more likely. Now, there is a hard no group, the 15% who say they definitely are not going to get a vaccine, and that was higher among Republicans, with 1/4 of the Republicans. So that, of course, is a tough group. Now, keep in mind that this applies to other elements for COVID prevention. Individuals who resent authority are twice as likely to never wear a mask. And individuals who believe that the truth about coronavirus is being kept from the public are twice as likely to never wear a mask. And you can see how people of a particular political persuasion or communities of color that have not been, their lived experience is not to trust government, to trust authority. So you can see how that can influence people's viewpoints. Now, we do have some resources for all of you. And if you want to take your cell phones out and take a picture of this so you can figure out the back to the site. I'm sorry, it's not a very convenient, memorable link, but there is a report from the NIH called the Vaccine 19 Vaccination Communicator. The subtitle is Applying Behavioral and Social Science to Address Vaccine Hesitancy and Foster Vaccine Confidence. And that is a report that has an executive summary and is quite interesting. So if you have a relative or a loved one, or if you yourself are vaccine hesitant, it might be interesting for you to read this report. The CDC has packaged this in very user-friendly ways, and they have their own health systems communication toolkit that has used elements of this NIH report. And I just wanted to bring this to your attention, that these are resources that are available. So here's what I recommend if you think that getting a coronavirus vaccine is a good idea, which I certainly think it's a good idea, because we're not going to get out of this pandemic and we're not going to stop these deaths. And we're experiencing about 3,000 a day. And about a week and a half ago, it was 4,000 a day. These are, we've already killed almost as many people from coronavirus as all of World War II combined. And it's just an inexorable rise, because this is a nasty, lethal virus, especially in our most susceptible individuals. And we know persons of color have jobs that make them more susceptible. They may have underlying medical conditions. They may not have the kind of health insurance that gets them ready access. For a whole host of reasons, they are more susceptible. Did you know that men are more susceptible to death than women? And that's not a trivial difference. Men are substantially more likely to die of coronavirus than women, and we think there are biological reasons for that. The elderly, I happen to be in that age group as a 66-year-old. I am more likely to die of coronavirus than most of you listening. And anyone with an underlying medical condition. And then there are random cases. We don't know why the occasional child gets the MISC, the multiple immune system disorder of children, similar to what's called Kawasaki disease, this serious inflammatory complication. So it's not very common, but what if it's your child? And it's also not very common for an adolescent hockey player, football player, to get post-infectious cardiomyopathy, a very, very serious disease of the heart. But it happens. So the notion is we would like to coax people to seriously consider and get the vaccine. So tailor the message to information needs and values of the intended audience. If you're talking to a person of color who is skeptical about being a guinea pig, remind them that 17 million Americans have been vaccinated. Remind them that a big chunk of them are doctors and nurses. And you will see people's viewpoints shift in communities of color. Because their main concern is this another experiment on me because I'm available? Is it really safe? That's the question. And after the Tuskegee study and so many abuses of minority communities, it's a very reasonable question in my view. However, if you've got somebody who says this is a government plot, they invented the virus and they're trying to infect us with the vaccine, this is a completely different messaging. And you're going to do well if you say, yes, I can understand how you might feel that there's a suspicion. But what do you think about all these doctors and nurses getting vaccinated? What do you think about the death rates in nursing homes starting to go down? Perhaps you should rethink this. Perhaps it is a serious virus, wherever it came from. Maybe the Chinese had it released from a lab. We don't know, but regardless of its source, it's now plaguing Americans. You could also use be the protector do you care about your family, your clan, your community? If you do get a vaccine, it will help protect your loved ones in your community. That might be a better messaging for that conspiracy theorist or someone who is a libertarian and saying, you can't force me to take a vaccine. You say, we're not forcing you. We just think it's a good idea for you and for your community and your loved ones and your family. That's a better messaging in that kind of opposition. And then we've got an even a third group, which is organic foods, and I happen to love organic foods and vegetarian diets. I happen to be one of them too. But people who are a little bit new age, and you're not going to put a foreign protein in my child's arm or in my arm, that this is an artificial product. And then you may be able to win them over by describing what an messenger RNA vaccine is, what the components are. There's a little fat lipid coat, etc. And then frame vaccination as a social norm. If this is what you're going to be doing, you're going to be doing what well-informed people are doing.
Thank you so much. Oh, okay.
Almost done. Then don't do this. Don't use negative emotions. Don't use judgmental language. Don't say you're going to be forced to vaccine, because I don't think we're going there. And don't politicize vaccination. Don't start with a Republican versus Democrat thing. It's not going to work. And I'm going to skip the rest of the slides because I over-prepared and over-talked, and we'll go on to the rest of the panelists. Thank you.
No, that is such helpful information reaching communities of color, and the vaccine is so important to getting us back to whatever we define as normal, and the economic impact to people of color and the deaths has been, as we mentioned, disproportionate, and we need to get everyone vaccinated. Dr. Musi, I do want to talk a little bit about some of the disparities that were highlighted around child and maternal health. And this is thinking about where are we so today we're at the vaccine, but let's also take a step back to where we were before. And then how is this even showing up in COVID for women who are pregnant? How is that showing up in COVID today as well? So I'd like to hear your perspective.
Thank you, Tiffany, for the great introduction and your piece as well. And Sten, my head was vigorously bobbing as you went through your slides and in agreement with everything that you're presenting. So give me a minute. My portion is really addressing the issues of maternal mortality and maternal health in the COVID pandemic. And I feel very strongly that in order to effectively address the Black maternal mortality crisis that we are facing in the United States, we need to pivot the conversation away from race as the risk factor to racism, both structural and institutional. And there's a long history of obstetric racism in the United States. As this racism relates to Black bodies, this began with the arrival of enslaved women in the United States in 1619. Their bodies, when not laboring in the fields of sugarcane or cotton, were in labor to provide as many children as possible to further enrich their slave owner. Genital trauma as a result of sexual abuse, childbirth, or genital disease impacted an enslaved woman's fertility and thus her value and ability to contribute to the workforce. In this environment in 1845, we saw Dr. Marion Sims, who performed gynecological surgical experimentation on enslaved women with obstetric fistulas. Between 1846 and 1849, Dr. Sims performed obstetric fistula repairs without anesthesia, without antiseptic, on 11 enslaved women. His goal was to perfect the technique of obstetric fistula repair, which he was able to do and was credited with this repair and hailed as the father of American gynecology. He treated rich white women with this technique that he perfected on enslaved Black women And by his account, he became the second wealthiest physician of his time. A statue of him stood in Central Park until 2018. The impact on Black women's bodies was the beginning of a legacy of dehumanization and traumatization in the medical space.
And
that slide reflects how it started. This slide is how it's going. Since the CDC initiated its pregnancy mortality surveillance system, they've been tracking pregnancy-related deaths in the United States. There's been much media speculation about the reasons behind the increasing maternal mortality rate in the US overall. But where there is no question is the considerable variation in this rate between different races and ethnicities. And as you can see here, non-Hispanic Black women are almost 3 times more likely to die than non-Hispanic white women. Some examples of how institutional and structural racism affect maternal health outcomes can be seen above. We see how individual factors, such as access to public insurance versus private insurance, access to social support, childcare, and immigration status can affect your ability to utilize the existing prenatal care networks. And these are intertied with race and ethnicity. In addition, we see community and societal factors. We know in the US, we see it, that there is residential, occupational, and educational segregation of marginalized and racialized groups to low-quality neighborhoods, schools, or jobs. As far as biological factors, we see that there's targeted marketing to these communities of health-harming substances, such as sugary sweet drinks or cigarettes. This entire environment then comports into disparate experiences with the prenatal care network and disparities in maternal care outcomes. We also see how racial bias plays out in the field of reproductive health. We see that there are diagnostic lapses that occur disproportionately to Black women. This slide here is taken from a paper by Dr. Jasmine Johnson that she presented at SMFM last year. They looked at over 1,000 women who had had a C-section and looked at their postpartum pain evaluation and treatment. The first box here shows the percentage of women who had a pain score greater than 7. And you can see at 0 to 24 hours postpartum, non-Hispanic Black women reported the highest pain score. And in addition, at 24 to 48 hours, the highest proportion of a pain score greater than 7. They then looked at the number of pain assessments that were performed for these patients by race and ethnicity. And despite reporting seeing a higher percentage of women with more severe pain, white women had the highest number of pain assessments, and this was statistically significant across the races. In addition, they looked at the pain treatment that was given by quantifying how many equivalents of oxycodone each patient received. And despite their a greater proportion of severe pain scores, Black women received less oxycodone equivalents than white women. And these were seen as statistically significant difference across the races. And we see here echoes of a lack of acknowledgement of Black pain.
Dr. Mucci, as you're continuing, everyone is so interested in seeing your slides, but they're having difficulty. So I'm not sure if you can make your slides a little bit larger. We also sent it out just so everyone knows there's a link in the box so that you all can get access to the slides on your own. And perhaps if you go to slideshow and just do the start. Yeah, the share the slides. Thank you so much.
Share a different screen. Maybe try that. Stop share, and then I'll try to screen share one more time. I'll go into to that mode, maybe.
Sorry to pause you, but everyone is interested in your slides and we've got a few notes.
Okay, let me try doing this. So if I do screen 2, how's that? Is that clearer?
That's better. Thank you so much.
Figured it out. Okay. In addition, we also see Black women reporting experiences of neglect, dismissiveness, or disrespect. And one of the cases that comes to mind very easily for a lot of Black women is the case of Serena Williams, who despite her wealth, her tremendous fame, still felt dismissed and had to push aggressively to get her pain and her discomfort needs addressed in her postpartum experience. And finally, we see coercion. Particularly, we see this in the field of reproductive health. We've heard of the cases in 1970 of the Ralph sisters who were sterilized at the ages of 12 and 14 because their mother, who was not able to read or write, signed a form that she did not understand. We see it in the case of Darlene Johnson as late as 1992, who was about to be released from a 1-year jail sentence for beating her children. The conditions of her probation were mental health counseling, parenting classes, and the implantation of the Norplant reproductive health control system. She initially agreed, but then changed her mind and was only able to get the third condition dropped by bringing a suit with the ACLU. So I've talked about the problems, but how do we move forward? How do we move towards equity in maternal health? And I've tried this is complex, but I've tried to stratify it into 3 areas: the individual, the community, and the society. At an individual level, and I'm speaking largely as practitioners here, as healthcare practitioners, I believe that there should be an increased emphasis on education and training regarding biases. There's some data now out of New York talking about how standardized approaches to common issues in obstetrics can help to reduce racial inequity. In addition, personally adopting and supporting a questioning attitude towards business as usual, towards the status quo, towards how things have always been done. For example, advocating for labor support or patient advocates for our laboring mothers, such as doulas. Screenings for social determinants of health in our prenatal care and following up on those each trimester. And acknowledging the impacts of institutional racism in our care and treatment plans. On a community level, we need to see more challenging of policies that support institutional racism. I'd like to see the introduction of reproductive health education in the curriculum further strengthened, and strengthening our public health infrastructure, which COVID has shown us is in need of some boosting. In addition, the use of community healthcare workers in addressing some of the social determinants of healthcare that our patients face. And finally, on a societal level, intentionally, and setting this as a political priority, the addressing of healthcare inequity. The coronavirus pandemic, as you know, has impacted us on a major scale. In the United States, and this is as of December, there have been about 42,000 cases in pregnancy and 55 maternal deaths. If I can go back to this prior slide, we have seen how COVID has impacted these individual factors and affected our prenatal care utilization disproportionately for Black and Brown women. As far as COVID-19 and pregnancy, we do know that relatively speaking, there are increased risk, pregnancy presents an increased risk of severe COVID disease. Overall, women have an increased risk of ICU admission, an increased risk of requiring mechanical ventilation, and an increased risk of death. And the risk factors for poor outcome are hypertension, diabetes, cardiovascular disease, but as I mentioned, the racial disparities persist. We do now have a COVID vaccine, as Dr. Vermont had mentioned, that has been shown to be very promising as far as efficacy in reducing the likelihood of severe COVID disease. What has been difficult in our pregnant patient population is that this vaccine was not directly studied in pregnant individuals. The current recommendations from ACOG, which is the governing body for obstetricians and gynecologists in the United States, recommends that the COVID vaccines should not be withheld from pregnant individuals who meet the criteria for vaccination based on the current recommended priority groups, and that they should be offered to lactating individuals similar to non-lactating individuals. But importantly, that we should be giving patients the full information that we do have available about the safety and efficacy of the vaccine, including information about data that we do not have available. And this is adapted from the working document that we're using here at Yale Medicine that Dr. Uma Reddy, Dr. Chris Petker, and Dr. Heather Lipkind helped put together. That having this conversation with our pregnant patients is a shared decision-making conversation, where we're talking about the risk assessment of their exposure to and becoming ill from COVID-19. Because for our pregnant patients, the discussion of not taking the vaccine is not simply not taking the vaccine and all is well. The risk, the counter to that is then your potential exposure to COVID-19. And this is impacted by various things: the level of activity of virus in your community, your personal risk of contracting COVID-19. So for example, if you have a patient who's a respiratory healthcare technician, environmental service worker, working in the ICU on the COVID units, their risk of exposure is much more significant. And then other personal risk factors that our patients may have for more severe, that would contribute to a risk for more severe form of COVID-19. And as Dr. Vermont mentioned, also taking into consideration their personal beliefs and preferences regarding the vaccine. I want to stop right there and take any questions or comments or
Well, we'll preserve some of the questions for our Q&A portion, which we'll get to pretty shortly. I did want to turn it over to Dr. Blanco, and we've already talked about a lot of the disparities, a lot of the mistrust for communities of color in the healthcare system, and that some of it is really stemming from the healthcare workforce itself. I just want you to lend us some of your expertise on what are some of the solutions, what are you seeing in the field, and what are you working on as well to address some of the disparity issues?
So, we need to think about disparities. And I think, Dr. Mushi and Dr. Vermont really emphasized this. Disparities exist across the spectrum of medicine. There's not one field that's not impacted. So I'm a rheumatologist and I talk about disparities in rheumatology all day. Dr. Mushi is OBGYN. She's talking about disparities in OBGYN. Dr. Vermont, he's infectious disease and pediatrics, and hence he's talking about disparities, really across the gambit. And I think that's what we really have to really think about, that, when we talk about the social determinants of health, I think, and Sten, you can potentially correct me on this, where it's estimated that about 70% of all morbidity, so all the bad stuff that happens to you because you have a chronic illness, actually stems from the social determinants of health, right? And if we address those factors, right, patients get better, because there's not one chronic illness that's not going to be impacted by access to healthcare, by low general literacy and health literacy, for unemployment, poor housing, right? So I think that we need to open up the discussion more. And this has been a very fraught topic. And I'm sure Dr. Mushi and Dr. Verman can back me up on this. I feel like for a very long time, we've talked about disparities in a very genteel sort of way, in saying, oh, you know, there's these differences between Black patients and white patients and Hispanic patients, and saying them in a way of like, I wonder why this could be, instead of really naming the issue. And I think, you know, Juliet, your slide, like, let's get away from race and let's talk about racism, right? Because this is what is at the heart of a lot of these disparities. Racist structures were implemented in order to segregate people by the color of their skin, and then subsequently led to poor housing, poor education, poor outcomes. And these systems morph and permeate, like not only permeate, but also permutate. They shift and they switch, and then they go by other names, etc., to really infiltrate the entire process. And so, you know, and part of it is, yes, on average, most physicians come into medicine, idealistic medical students. I want to help people. But frankly, we're all raised in a pretty toxic stew of media imagery and propaganda telling you that one group is the ideal group and one group is not. And so you bring in these biases. So when you're treating your patients, biases come out, right? And so it's what we need to do is now, you know, educate our medical students, educate our providers, educate our doctors, our nurses, our PAs, our techs, everybody, to say, well, you know, we all have biases. We've all been brought up in this just really unhealthy environment that has, you know, really taught us that one population should be elevated above others. Let's figure out within ourselves how to combat that, but then to take action. What we see now in a lot of diversity trainings is people will say, oh, well, I have bias. I have bias. I have bias. You know, what can I do? I have bias, right? And what we need to do is move beyond that and say, well, now that you know, right, do better. If you know better, do better. Because it's not enough to just say, I have bias, and to wash our hands of the situation. It's now that we know that we have bias, how do we enact systems within ourselves, within our own practices, as well as across the system, to address all of these biases?
Thank you. That is really helpful in thinking about what is the role for us in training, but the personal role as well, to move beyond recognition, to think about what are some of the solutions that we can enact to improve. So thank you so much for that. And I just want to remind the audience that you can place your questions in the Q&A section as we are going along. But I think we honed in on some of the solutions along the way about what we can do in order to improve this desperate world that we're in right now, and even with COVID. One of the things that our state is considering, and Dr. Vermund, I would love to hear your thoughts on, is declaring public racism as a public health issue. And we've seen other states do that and react to that. And our state is considering that. And I know that there's some towns who have done that already. What are your thoughts about that? And what can we do if we make that declaration as a state?
Let me throw two examples on this issue. One is access to healthcare. So when the Obama administration developed the Affordable Care Act, popularly known as Obamacare, it was designed to fix a big hole the American healthcare system, which is that the working poor didn't have health insurance. So if you were very poor, you could get Medicaid. If you were old, you could get Medicare. But if you were working poor, somebody working for minimum wage, somebody working 1.5 jobs, 2 parents working minimum wage jobs, neither of those jobs had health insurance, and they couldn't afford health insurance. And as a practicing pediatrician for many years, I dreaded the circumstances of the patient without health insurance, because they typically brought their child to me late in the course of status asthmaticus, or late in the course of diabetic ketoacidosis, or whatever the chronic illness the child had. They were trying to avoid a $3,000 back then ER bill by trying to manage it at home, and they would wait too long. And now the child was very sick. And guess what? The child had to be admitted at massive cost to society. I mean, it was the perfect lose-lose. So President Obama and his team choose this solution, which is very much in a private sector mode. It's actually designed after Romney Care in Massachusetts, designed by a Republican governor. So that's how far President Obama went to accommodate concerns of the Republicans. But back then, we were in the mode where the Republicans would block everything that President Obama did, but it got approved anyway. So Obamacare became the law of the land. But shockingly, I forget the exact number, 20 or so states chose not to take the 90% subsidy from the federal government to expand Medicaid to the working poor. Now, that is a perfect example of systemic racism, a perfect example of political decision-making that selectively hurts persons of color, and is a perfect example of racism as a health emergency, as a health crisis. And we need to be calling this out for what it is. It's not states that don't want to pay the 10%, because that's a trivial amount of money. The feds were covering 90% of the costs. These were states that really did not have a commitment to the health of the working poor, who are disproportionately persons of color. So there's just one example. I had another example that I was going to throw out there, and I got so excited about the first one that it flew out of my head. But I could give dozens of examples. Let me give the example of how we fund schools.
Yeah, and we can let Dr. Blanco jump in as well, but I'd love to hear your
I mean,
other.
that's a perfect example, right? And it's this. And honestly, if we're going to talk about the legacy of Dr. King today, right? Remember that he was tackling poverty at the end of his life, right? It was not, and that intermingling, as you pointed out, Tiffany, of poverty with socioeconomic status, because the system was designed to segregate, but also impoverish, right? To suppress. And so, and it's this philosophy, and I just can't for the life of me understand this, honestly, like just denigration of the poor, right? Is if they don't deserve healthcare. If you can't afford it, well, then it shouldn't be yours, which to me is absurd, because I think at least the three of us on this call view healthcare as a human right. It is up there with water and food and shelter and, clothing and warmth from the cold. You can't say, right, that people don't deserve to be cared for, especially if this is why we got into medicine. We came into medicine to take care of people. And these are people at extremis, and all of us have had these experiences where people come in very, very late stage. And then by then, now it's the game of, well, now I have to put you out on disability because your rheumatoid arthritis has gotten so bad that you can't work. but the disability is not going to cover your bills. So what's that going to do to the rest of the household? Right? And it's getting providers to actually talk about these things. So I was giving a talk to some colleagues at a different institution, and we were talking about how Dr. Mushi had mentioned addressing the social determinants of health in the clinical encounter. And one of the senior faculty members who trains the trainees, right? So the future rheumatologist was like, well, Dr. Blanco, you know, like, how do we maintain our professional boundaries if we're asking all of these questions? And this is a senior physician. I was flabbergasted, frankly. One, because rheumatologists, we form very long-term relationships with our patients. So I'm like, really, you're going to know somebody for 30 years and not ask them if they have a job or if they're married or like what their life is like? That to me is absurd. But number two, if we're in the middle of a pandemic, and especially where this person is practicing, the Black community is facing unemployment rates of upwards of 30%, right? You're not going to go, hey, is everybody okay at home? Everybody's like, how's everybody with work? Anybody gotten sick? To me, that's just a basic kindness that you extend to your patient, but also key information that I need to know. You know, people have pride. They may not necessarily want to share this, but if they lost their insurance, right, to Sten's point, if they lost their insurance, rheumatology medicines after cancer medicines are some of the most expensive in period, right? Only cancer medicines are more expensive than mine. So if I'm not asking if everybody's has a job, if everybody has insurance, right? If the head of the household is actually still able to work and provide, because we've seen such horrible disparate rates of COVID in our communities, I'm not taking good care of our patients. And this is what we need to teach our trainees, that it's not just about the medicine and the molecule and the pathology, right? It's thinking about the environment under which our patients live and how much their environment and everything that goes into that is what's truly going to dictate how well they're going to have, like how well they're going to do with their illness, right? How well they're going to be, how well they're going to go through their pregnancy, how well they're going to have, you know, whatever outcome happen to them. And we don't talk about this enough in medical school, and we don't talk about this enough in training, because again, there's these antiquated ideas of, oh, we must maintain these professional boundaries, etc. When if you think back in the day, the doctor was embedded in the community, was such a core part of the community, right? People, everybody knew the doctor. The doctor made house calls. What better way to figure out how somebody is doing than to go visit their home, right? To really see how they live, to see what the dynamic is in the family, etc. And so, you know, for example, so one of the things, so I'm at Einstein Montefiore, so I'm not in Connecticut, I'm in the Bronx. And I actually live in Jersey, so I'm at the opposite side of New York from you guys. You know, is that for my trainees, I actually take them on a community tour of the Bronx. It's not a tourism tour, though. I don't take them to Yankee Stadium. I don't take them to the Botanical Gardens. I don't take them to the Bronx Zoo. They could do that in their own time, right? But we actually take a physical walking tour of the Bronx with a historian to talk about things such as racism and redlining and discrimination, et cetera, but for them to actually walk through the Bronx. Because more often than not, people take public transportation in, they take public transportation out, and they never go to the bodega. They never go to the Target. They never go and see people in life, in the way they really live. So their only context of their patient is through their pathology, which frankly takes out the human in the encounter, right? It's how do we get to know these communities, right? Well, let's go get some coffee in these communities. Let's go grab a bite in these communities, right? It you know, completely demystify, you know, your crazy notions that you have of the Bronx and actually teach you who your patients truly are.
And I just want to echo that, Dr. Blanco, you know, there's this, you know, purist idea of health as just about the biology and the medicine. And I think increasingly, but it's taking some time and some questioning, of the system, of understanding that healthcare is absolutely political. It's about power and who's getting access to that power. And the need for an intentional setting of political goals to address this is absolutely critical. So that's, getting back to what you were asking, Tiffany, about the need to set this as a public health priority and engage it in the political agenda. We're not going to move forward without it, because those political systems that fed into this healthcare system are what have got us here in the first place. So without addressing that, we're going to be spinning our wheels.
And it's creating the structures behind that, right? Like where's the teeth,
right,
in that declaration?
Right.
I mean, because declaring racism as a public health crisis, you should have done that, right? Literally the day people landed on this continent, right? And brought plenty of pandemics and plagues, right? In the 1400s and so on. Racism has always been a pandemic. Racism has always been a national healthcare crisis, right? So just to say it right now, great, good. I'm glad we're saying things out loud now. But what are the policies? Where are we going with this, right? After, for example, the horrible events of May 25th, when we all collectively watched George Floyd be murdered, right, on television. People woke up. However, there were communities that were screaming about this
way back
for hundreds of years, right? So good. Again, I'm glad that we're finally having a dialogue, but where is this going, right? Where are we going to truly enact policies that will affect change?
And that was one of my next questions in the last minutes that we have, and even a question from one of our audience members is thinking about what are some of the solutions? How do we, if we were a panel that was designing racism as a public health crisis and we're designing the policies behind it, what should we be recommending? What should we be doing so that the conditions are better for all?
Maybe I could share a quick vignette that is an example, something positive. The Connecticut VA system is serving our veterans. And a good chunk of veterans in the VA system are elderly, another chunk are Black and Hispanic. And not every veteran has come back to a great job and a middle-class lifestyle. Some of them are homeless, some of them have substance abuse challenges, some of them acquired addiction when they were in the military. So what the Connecticut VA did with its sister VAs and clinics in the state is they built a very strong database linkage between the electronic medical record of the VA and the social services records of a variety of key organizations, so that the doctor knew when a patient was housing insecure or homeless. A doctor knew when a subject was food insecure or hungry. They knew when they had not come to their substance abuse appointment or their mental health appointment. And they started having an information sharing, which really should have happened decades ago, but started to happen when this system was developed about 5 years ago. And Connecticut, make a long story short, Connecticut became the first state in the United States to meet VA objectives for no homeless veterans in the state of Connecticut. It works. It works when you bridge the social services and the medical care, and you handle the social needs at the same priority or higher priority than the medical needs, rather than neglecting the social needs and just hemorrhaging resources and money on unnecessary hospitalizations, preventable chronic conditions, just foolishness in our society that drives our healthcare costs to be the highest in the world. So there's an example of a concrete activity that could be done writ large, not just the VA system, but our entire state system, which is, by the way, very analogous to how some of the socialized health systems in Europe work. They are very attentive to the social needs, and they have a larger investment in making sure someone has a home, has job training, has substance abuse services. They spend a lot less on incarceration, a lot less on healthcare, because they don't need to spend as much on healthcare anymore because they're keeping people out of the hospital.
Dr. Mishi, Dr. Blanco wrote recommendations as we are wrapping up, since racism, as one audience member said, is often implicit. What can we do in our healthcare system? I think you highlighted some things before, but as we're wrapping up, what would you leave us with?
If I had to pick one thing, I think I would focus, on an individual level. And that is for practitioners to give our Black and Brown patients the space to voice their perceived concerns about racism, especially practicing as a Black physician in Greenwich, which is a traditionally very white space. I see a fair number of, Black and Hispanic patients who, seeing my Black face, feel like this is the first time that they can share their concerns about, will they be seen during their labor process? Will their requests be honored? I've had patients ask me, will my pain be ignored? And just even having those conversations and creating that space to acknowledge that fear goes a long way as far as, I think, managing some of the maternal stress that our patients carry coming into the labor process. And I think that can be expanded to pediatrics. It can be expanded to virtually any field, that, patients of color are walking into these spaces and worried about how they will be perceived in the space, and will that impact the care that they receive. And having the practitioner create that dialogue from the get and openly discuss how they're going to target that and avoid it for them creates a sense of relief for our patients. So that's one simple individualistic, individual level practice change that I would talk to.
Thank you. And Dr. Blanco, thank you so much, Dr. Mishi. And Dr. Blanco, as you're answering this question, can you also put a lens on the curriculum for providers and what can be done? So what would you also leave us with?
Sure. So, I think, Dr. Mishi brought up a huge point without really addressing it head on. I think the diversification of who the doctors are, right, is important, because we will bring the voice of the community into the medical schools, into our research, into the hospital, into the teams to say, listen, when we're on rounds, why is this not happening for patient so-and-so, right? Because we, more often than not, medical students of color come in wanting to go back and serving their communities. So they're coming in with this perspective, and this also happens for investigators and researchers of color. More often than not, health disparities applications for grants, etc., very commonly are by investigators of color. Why? Because they're studying the issues affecting their communities, right? But we have so few doctors of color that it's going to take a really long time, to be honest. So we need to train every professional to have those discussions, right, that Dr. Mishi is saying, to be fearless and to be courageous. A lot of providers, and let's just put it out there, a lot of people that identify as white may not necessarily have the same conversations that Black and brown patients have with regards to race on average around the dining room table, right? They're just not. So we need to teach our trainees how to have those conversations, respectfully with their patients, right? So just, and honestly, like you see the patient's face, it's like they exhale because finally somebody's acknowledging the elephant in the room, right? And that goes to the curriculum, right? Not only teaching them that racism exists, not only teaching them that they have bias, but also teaching them then how to address the racism and the bias within the clinical encounter so that they can make their patients feel a lot more comfortable, and having that dialogue, which can feel very unnatural at first. But, you know, when you go into medicine, you're learning a new vocabulary, you're learning new skills, all of it feels uncomfortable. So we can add this too, right? I think, again, people have this notion of like, oh, that's private. Oh, we don't talk about those things. No, well, this is what, you know, hundreds of years of not talking about this has gotten us, right? So let's start talking about it.
Thank you so much. And we are up on our time. Thank you guys so much for all of your expertise and for how much you shared. I just want to spend 30 seconds on some of the top things that I heard. The first one being we cannot separate the social needs from the medical needs for an individual. And so we need to figure out as a way, as a profession, how do we continue to make that linkage? And Dr. Vermond, you spoke about the use of data and how we can make those connections with data, but you also spoke about how in the healthcare profession we can make those connections by conversation and by discussion and by elevating that those conversations need to happen. One of the things that we also discussed is that we need to build a cultural awareness in the curriculum and cultural humility. I think that's what you're speaking to, or both of you all, Dr. Mushi and Dr. Blanco were speaking to, is making people aware of their unconscious biases and then building humility and mechanisms by which they can address and demonstrate that cultural humility with their patients so that they can have better conversations and better insight in how to heal individuals. We also talked about community health workers, and those are individuals who are from the community, of the community, who could be an important link to the healthcare system, and continuously thinking about access, Medicaid access, just getting people access to the system through the door so that they even have a chance to be and live their healthiest lives, and through the door before it's too late. So looking at, again, healthcare as a right and an access for all of us. And I will add the last thing, and from my perspective, is to make sure that we are just measuring this. We so long have ignored, again, populations of color, and we don't improve what we don't measure. So we need to make sure that we are really stratifying data by race, ethnicity, and language data in all of our healthcare systems and across the state so that we know how we're doing and we can build the right interventions. So I thank you all so much for your time, for your expertise, for being a part of this panel. I know we could have talked for another hour. So thank you all so much and for making it as concise as possible. I'm going to turn it over to Mary Lee, who is going to wrap up this evening.
Wonderful, Tiffany. Thank you so much to Tiffany Donaldson, our moderator, to our panelists, Dr. Blanco, Dr. Mushi, Dr. Vermond, for this profoundly important discussion this evening. And thank you to our guests for tuning in. We hope that you will continue to join us for these events and partner with us on our mission to eliminate racism and empower women. Please be on the lookout for an email with a link to a recording of tonight's event, as well as those slides many of you were asking for, and a toolkit of solutions and additional information about the topic we discussed this evening. So thank you again. Please wear a mask and take good care. Good night, everyone.